We are now going to talk about some other chronic neurological disorders, and the information is in Chapter 59 of the 9th edition and Chapter 58 of the 10th edition. Starting with multiple sclerosis, or MS. MS is a chronic progressive degenerative disorder of the central nervous system. Typically, the onset is found in 20 to 50-year-olds, although there's always a few outliers that can be diagnosed before 20 and after 50. Women are affected 2 to 3 times more than men with MS, and it's more prevalent in temperate climates such as northern US, Canada, and also Europe. So they don't really understand what causes MS. They know there's a relation to an infection, genetics, and also MS being an autoimmune disorder, so there's an interplay of those factors. It's not caused from one single cause or factor. And smoking, physical injury, emotional stress, excessive fatigue, pregnancy, and a poor state of health are also associated with MS. Women who are pregnant may experience remissions or improved symptoms during pregnancy. And this may be related to shifting of hormones that affect the immune system. And there can be certain triggers in the environment in the susceptible individual that can then lead to MS. What we do know is the pathophysiology behind MS. There are 3 different processes occurring that characterize MS. There's chronic inflammation, demyelination, and scarring that occurs in the CNS. So initially you have this chronic inflammation occurring. This is the body attacking itself, and it's attacking the myelin sheath. And as time goes by, the myelin sheath can be repaired, but if it continues to be attacked, you have demyelination, and it cannot be repaired or regenerated. And so finally, you have scarring in the CNS, either in the brain or the spinal cord, that results. So initially, the damage to myelin sheaths is in the brain and the spinal cord, and your patient may complain of some impairments of function, and then you have the ongoing inflammation and the inability to regenerate of the myelin. Then eventually nerve impulse transmission is disrupted without the myelin sheath being present anymore. So it's really important to understand what kind of symptoms are present with MS. Your big ones here that we're concerned about are weakness, and they might have some paralysis, diplopia or double vision. They can have scanning speech, which is kind of considered a type of explosive speech or a change in articulation. And there can also be spasticity of muscle. So those are kind of your big motor symptoms seen with MS. The sensory symptoms, one of the first symptoms that can occur in MS is visual changes. So they start to have this patchy blindness and blurred vision. Those are kind of your first initial symptoms occurring. There can also be vertigo, tinnitus or decreased hearing, and what's called Lerimet's sign. This is where you have an electrical type of sensation that runs down the back of the patient into the limbs. Other cerebellar signs and symptoms can be ataxia or incoordination, rapid eye movements, nystagmus, dysarthria or difficulty speaking or speech or with speech, and fatigue. Fatigue is a big one that can be very life-altering and debilitating to patients. So that's another big symptom in patients with MS. Bowel and bladder dysfunction can also occur. You can have constipation. The person might have a spastic bladder, which leads to incontinence because it's constantly spasming. Or the person can have a flaccid bladder, which is where they retain the urine and they have no sensation to urinate. So it's just kind of building up and retaining in their bladder. Some emotional signs and symptoms that can be experienced are anger, depression, also euphoria. So there can be this roller coaster of emotions experienced. Cognitive signs and symptoms include difficulty with short-term memory, attention span, information processing, planning, visual perception, and word finding. General intellect and long-term memory and conversational skills, reading comprehension, those sorts of things typically are unchanged. So most of these cognitive issues will happen later in the course of the disease. With MS, there are different patterns that can occur. So they can be a chronic type of pattern with progressive deterioration, remissions and exacerbations in other patients, and then progressive deterioration in neurologic function with repeated exacerbations that can occur in other people. So the intermittent nature of symptoms may dissuade the patient from seeking out medical help because they are okay for a little while, they're experiencing a remission, and then they experience an exacerbation. So this back and forth might make it difficult for patients to understand what is happening to them. Also, the vague symptoms that are occurring intermittently over months and years may cause the patient to not seek medical help or to get a diagnosis until much later on in the disease process. So these are those patterns I was talking about. So you have the relapsing, remitting, primary progressive, secondary progressive, and progression relapsing. These are different types, characteristics of the disease. You don't need to memorize these. The most common one that is seen is the relapsing remitting. So you have the exacerbations and the remission pattern. So due to the spotty distribution of the damage in the CNS, there will be lots of different types of manifestations occurring, and it's very individualistic. So the diagnostic studies that we're really wanting to do for MS are kind of a series of things. We have to look at a health history, we have to look at clinical manifestations, and look at results of certain diagnostic tests. There isn't one definitive test that we can use for MS. We're going to look at the MRI of the brain and the spinal cord. In this, we can see presence of plaque, inflammation, and atrophy, as well as tissue breakdown and destruction. We might also see white matter lesions that are forming in the brain and the spinal cord. It's important for the actual diagnosis of MS that we have evidence of at least 2 inflammatory demyelinating lesions in at least 2 different locations within the CNS, and that we have damage, a history of a damage or attack occurring at different times, usually about a month apart. So those 2 things are very important. We want to be sure we are diagnosing the patient properly. It can be very difficult for people to have this diagnosis, so we want to be absolutely sure that we are giving them the correct diagnosis, and we're going to rule out all other possible diagnoses. The treatment for MS is unfortunately not cure-based. There is no cure for MS. We have to treat the disease process and provide symptomatic management. So our therapy is going to be tailored to what disease pattern the patient is experiencing and those manifestations that that specific patient is going through. So the different treatment options that we have with medication therapy, number 1, we have these immunomodulators. Immunomodulators are going to weaken or modify the immune system. We know that this is an autoimmune disorder, so if we modify the immune system, maybe we can allow for that immune system to stop attacking itself. So there's many drugs that are given as immunomodulators. Beta interferon is one of those. Managing exacerbations is our next treatment goal. We want to treat those exacerbations by typically giving the patient corticosteroids. This is going to decrease the inflammation and edema occurring. And then third, we're going to do symptom management with a series of different medications. For instance, muscle relaxants, we're going to treat spasticity by giving muscle relaxants. CNS stimulants are going to help with that debilitating fatigue that is often experienced in MS. Anticholinergics are good for those bladder symptoms, signs and symptoms, to relieve some of that spasticity occurring. The TCAs, tricyclic antidepressants, are used for chronic pain that can be experienced, the neurological pain that happens in MS. And then also anti-seizure medications help with chronic pain, especially Neurontin or gabapentin is one commonly used for that neurological pain. Other treatments that are used to help, especially with the spasticity, they might do surgery, they might do what's called a neurectomy. They remove some of the nerve or the nerve root in the spinal cord to decrease the tremoring, the spasticity occurring. There's also dorsal column electrical stimulation that can be done. It is a nerve stimulator that can be implanted into the spinal cord. This is going to decrease the tremoring of the body and increase mobility for these patients if somebody has a more progressed type of MS. There's also intrathecal baclofen pumps that can be implanted in the patient to help with muscle relaxation, again, treating that spasticity and tremoring. As far as nursing goes, we want to, number one, help the patient manage the disabling fatigue. And the way we do that is by promoting exercise, encouraging exercise to help with the fatigue. We also want to encourage rest periods for the patients, having that balance of both. Number two, we want to maximize neuromuscular functioning. So we hopefully can try to decrease some of the neuromuscular loss that has occurred by symptom management. Number three, we want to decrease factors that precipitate exacerbation. So there are certain triggers that can lead to an exacerbation, such as extreme hot and cold, exposure to infections, fatigue. Those are triggers that can then lead to an exacerbation. So we want to decrease those as much as possible. Number four, we want to encourage independence and activities of daily living as much as we possibly can. We want to keep them independent. And number five, optimize psychosocial well-being. This can be challenging for patients that have a diagnosis of MS. They might be depressed and anxious and frustrated, but we want to try and optimize psychosocial well-being and address their mental health as well. Okay, Parkinson's disease is our next neurological disorder that we're going to talk about. With Parkinson's disease, there is a slowing down in the initiation and execution of movement. And the technical term for this is bradykinesia. In addition to that, we have an increase in muscle tone or rigidity. Many times patients have a tremor at rest, and they also have what we call motor instability. This is a disease of the basal ganglia, and it affects the forebrain, which is responsible for voluntary motor control. And there is a loss of dopamine producing cells in Parkinson's disease, which is also important for movement. The diagnosis of Parkinson's disease increases with age. We know that about 2%, it affects about 2% of people over the age of 60, but there are as many as 15% that are diagnosed under the age of 50, Michael J. Fox being one of those people. It is more common in men than women. Again, with Parkinson's disease, it's similar to multiple sclerosis in that we don't have an exact cause. There is an interplay of environment and genetics. There might be a family history, genetic component, exposure to toxins in the environment, which might trigger the disease, specifically pesticides. And there's also drug-induced Parkinsonism, where certain medications can lead to Parkinson-type symptoms, especially Reglan, Haldol, and drug use of methamphetamine. It's interesting to note that in the brains of Parkinson's disease patients, there are these Lewy bodies present. And Lewy bodies are clumps of protein that kind of block off the neuron and cause plaques and disruption. There are also pathological changes in the neurons in the substantia nigra. So there's a decreased amount of neurons. You can see kind of on this diagram, this picture of normal substantia nigra levels, and then the decreased amount in Parkinson's disease here. It's spotty amounts of those substantia nigra. And these are important. The substantia nigra is important because this is where the cells that produce the dopamine live. And we know that dopamine, again, is important for movements and extrapyramidal motor functioning. This is a PET scan in a patient with Parkinson's disease compared to a PET scan of a normal patient, and you can see the level of activity in a normal brain versus the level of activity in somebody with Parkinson's disease. The activity is very much reduced in the patient with Parkinson's disease, and there's some patchiness of activity noted there. So with Parkinson's, it's important to understand that the onset is gradual and insidious with ongoing progression. So it's a very progressive type of disease. Unlike MS, where you have these remissions and exacerbations, this is going to gradually get worse for the patients. You're going to have a classic triad of Parkinson's symptoms, and those are the tremor, rigidity, and bradykinesia. So those are your classic signs and symptoms of somebody with Parkinson's disease. So tremors, we know what tremors kind of look like, and these are going to be tremors at rest. So the person at rest is having a tremor, not just with movement. Also the rigidity, where they are tense in their muscle tone, is present. And then finally bradykinesia. And so bradykinesia is when they have that motor instability. They have a slow shuffling gait. They take short steps, kind of sliding their feet along. They kind of lean forward when they walk. So those are your classic 3 signs and symptoms. Some other signs and symptoms that you might see, again, with handwriting, you might see a tremor. You can see with this person writing their name, this is indicating a tremor present. They also might do pill rolling with their fingers. This is also indicating a tremor. And then this gait instability, this is showing you what that looks like, Parkinsonian gait. They can fall back, which is called retropulsion, and fenestration is when they are leaning forward in their gait. Non-motor signs and symptoms with Parkinson's can be depression. They might have anxiety and fatigue. They might have pain, especially with the rigidity experienced. That can cause muscle pain. They can have constipation, trouble sleeping, and insomnia, and short-term memory loss. And so we have to address these concerns as well for these patients. So what happens is, as the disease progresses, our risk or amount of complications are going to increase. So the patient is going to show increased complications with motor symptoms. They may have an increased difficulty with movements, moving around, initiating movements. Weakness might be increased. Akinesia, where they're not able to move at all, can happen. They might have neurological problems, and finally neuropsychiatric problems as well, with increased depression. Dementia occurs in about 70% of patients with Parkinson's disease. So other complications are dysphagia, which might result in malnutrition, could potentially lead to aspiration. And for this complication, we want to be careful about giving them smaller, easy to chew types of meals to reduce the risk of aspiration. General debilitation may lead to pneumonia and UTIs and skin breakdown. If they are not moving as much as they used to, these patients can be bedbound or chairbound. That's going to put them at risk for pneumonia and UTIs and skin breakdown. We want to encourage them to move. We want to promote movement by giving them aids to help them get up, help them get to the bathroom, help them get off the toilet, that sort of thing. Orthostatic hypotension can occur as a complication related to the medications being used to treat the Parkinson's. This can result in falls and injuries related to dizziness and syncope. So we want to assess our patients for the risk of falling, prevent any kind of ways that they can fall, things in the way, things to trip over. That's what I'm trying to say. There are no specific diagnostic tests for Parkinson's. The history and the clinical features really help with diagnosis. Diagnosis is made when at least 2 of the 3 characteristics of the classic triad are present in the patient, and diagnosis is confirmed positively when a patient has a positive response to the medications used to treat Parkinson's. So we're going to give them the levodopa, carbidopa medication, and if they respond positively, that is a good confirming way to diagnose Parkinson's. Treatment, unfortunately, there isn't a cure for Parkinson's. We are going to work on symptom management. So the drug therapy, the main drug therapy is Sinemet. Again, that's carbidopa, levodopa. It's going to replace the dopamine neurotransmitter in the body. Also, surgery can be used. It's going to help relieve symptoms. That's all we can do with this type of disorder is relieve symptoms. We cannot stop the progression of Parkinson's. And they will use surgery if the patient is not responding to other treatments, such as the drug therapy. What they might try is deep brain stimulation, similar to what they would do with a patient that has MS. They might also use ablation, which destroys areas of the thalamus. And that can actually help with the rigidity, the tremors that is occurring in Parkinson's. Here is a picture of what deep brain stimulation looks like. It actually is a probe that they implant into the brain, into the thalamus, and it's going to help control those movements and decrease the tremoring and rigidity that is occurring. And there's a little kind of monitor that's pulse generator is what it's calling it here, that is going to control the pulsation that is sent through to the thalamus. It's like similar to a pacemaker, I guess you could say. So nursing management of a patient with Parkinson's disease is focused on maintaining nutrition. Again, like I said before, we want to give these patients smaller meals to encourage them to eat, more frequent meals each day, bite-sized pieces, easily chewable things. We want to encourage independence by offering any kind of mobility aids to these patients. We want to give them ways to get out of bed, make it easier to get out of bed with grab bars. We want to have an elevated seat on the toilet to help them get off the toilets. We want to help increase physical exercise. There are several studies out there that are showing benefits of patients with Parkinson's riding bike, doing boxing even. So we want to increase that physical exercise to help keep their bodies moving. And then finally, we want to keep them safe and prevent falls as much as possible. Ways we do that are to keep the area where they are living safe and free of clutter. We also want to make sure that we're monitoring for any kind of side effects of medication to prevent them from having any injury. Because they already have some instability, they already have bradykinesia happening. So to help with that, we want to work on keeping them safe. Okay, we're going to talk about myasthenia gravis next, or MG is another name for it. So in myasthenia gravis, this is when antibodies attack the acetylcholine receptor sites and prevent muscles from contracting. We know that these patients are experiencing, again, like a autoimmune type of effect in the body where antibodies attack these receptor sites. What is happening is you have weakness in the skeletal muscle groups, and a lot of times what will be seen in the patient is this drooping of the eyelid or ptosis. So that's one of the indicators that myasthenia gravis is happening. They will also have progressive weakness to other muscles. It affects men and women equally, interestingly enough. It can be precipitated by stress, illness, trauma, temperature extremes, pregnancy, similarly to MS. Complications of myasthenia gravis are related to that excessive muscle weakness, especially weakness in the muscles that affect swallowing and breathing. And so if you have weakness in those muscles, you're at higher risk for aspiration and higher risk for breathing difficulties. Amyotrophic lateral sclerosis, or ALS, or Lou Gehrig's disease is another one. That is a rare progressive type of chronic neurological disorder. There is a loss of motor neurons that occurs. Unfortunately, life expectancy with this condition is very short. It's 2 to 6 years, typically from the point of diagnosis. It's more common in men than women. So the motor neurons become destroyed and are essentially dead, and they can no longer send signals through the body to cause movement to happen. So your symptoms will include limb weakness, dysarthria, and dysphagia. And so again, you have that weakness, you have that difficulty speaking, and then difficulty swallowing that are complications to this disorder. There is unfortunately no cure, and meds can be given to slow the progression, but again, it's going to progress and continue. We are just monitoring and treating symptoms. So these patients, we want to encourage range of motion with exercises and encourage interventions to help prevent aspiration, especially. Huntington's disease is another chronic neurological disorder that is a genetic type of disease. It is an autosomal dominant gene that, again, affects movement. In this disease, movements are excessive and involuntary, which is what they call chorea. Huntington's chorea is another term used. Movements of chewing, swallowing, and gait become severely impacted, and the life expectancy is really short, 10 to 20 years from diagnosis. This one also does not have a cure and has continued progression and worsening of the symptoms. Patients have a high risk of depression and high rate of suicide with Huntington's disease because of the severity of the disease, the life expectancy. And unfortunately, by the time of diagnosis, it's usually when a person has already had children of their own, and so this also puts their children at risk for developing this disease since it is a genetic disease. And so people with Huntington's disease die from complications of related to swallowing and aspiration, and then lack of movement and all the complications that come from immobility. Okay, and that is our last chronic neurological disease we're going to talk about. Let me know if you have any questions about any of the information from today. Thank you.